Welcome to the Essentials series. In this brief video, we are going to give you an insight about one of the important topics in the MRCP Part 1 exam. Wolff Parkinson White Syndrome. By Dr. Mamdouh Mohamed Ahmed. MRCP UK. First of all, Wolff Parkinson White Syndrome, or as known as WPW syndrome, is a conduction defect that is caused by a congenital accessory pathway between the atria and the ventricles. Accordingly, the cardiac impulse generated at the SA node does not follow its classical normal pathway to the AV node and then to the ventricle, but it bypasses the AV node and travels down from the atria to the ventricle through the accessory pathway. This results in premature, early depolarization of the ventricles. This premature depolarization results in the characteristic ECG findings that we will discuss later. As the conductive properties of the accessory pathway differ from that of the AV node, the velocity of impulse conduction in the accessory pathway is faster than its velocity through the AV node, as the accessory pathway does not have the delaying properties of the AV node. This clearly results in development of atrioventricular reentry tachycardia, AVRT. Again, one of the deleterious effects of this pathology is that atrial fibrillation, AF. When coexist with WPW syndrome, it can transform into life-threatening ventricular fibrillation, as there is no slowing down of AF at the AV node. Recognition of WPW syndrome on resting ECG is of paramount importance. WPW syndrome is characterized by a triad of short PR interval, slurred upstroke of the QRS complex, known as delta wave, and widening of the QRS complex itself. All of these ECG characteristics can be explained on the basis of early premature depolarization of the ventricles. It is important also to note that not only the depolarization is affected by this pathology, but also the repolarization is affected. This is manifest as ST changes that could be mistaken for ischemia. Then, what about management of WPW syndrome? Management of WPW syndrome depends basically on the clinical presentation. Radiofrequency ablation of the accessory pathway is the definitive treatment. Otherwise, medications that have showed proven efficacy include sotalol, amiodarone, and flecainide. It is important to note that sotalol should be avoided if there is coexistent atrial fibrillation, as prolonging the refractory period at the AV node may increase the rate of transmission through the accessory pathway, increasing the ventricular rate and potentially deteriorating into ventricular fibrillation. Thank you so much for watching this video. MRCP Online Team.